Welcome to CardioCast. I'm Dr. Jim Dwyer. This week, women are less likely than men to have post-STEMI events. An antiarrhythmic drug is rejected by an FDA panel of experts, and more. But first, thanks to all of you who've helped us make this podcast better by taking our short listener survey. We encourage those of you who haven't to complete the survey by following the link in the show notes. And now the news. Women were at lower risk of major cardiovascular events than men after non-ST segment elevation acute coronary syndromes, but they also remain undertreated with guideline-directed therapies. Those are the primary findings from a study by researchers at Massachusetts General Hospital in Boston, published in the Journal of the American College of Cardiology. The researchers analyzed data from 10 clinical trials with more than 68,000 patients who'd had non-ST segment elevation acute coronary syndromes. 29% of the patients were women. Women and men had a similar risk of major adverse cardiovascular events, or MACE, after their acute coronary syndromes. But after adjustment, women's risks of MACE, cardiovascular death, and all-cause death were significantly lower. When it came to treatment after an acute coronary syndrome, however, women were less likely to receive aspirin, P2Y12 inhibitors, or statins. Women at high risk were also less likely to receive those therapies. A Food and Drug Administration Advisory Committee has voted 11-2 against a recommendation that the agency approve a long-studied antiarrhythmic agent for cardioversion of recent-onset atrial fibrillation. It was the second time before an FDA advisory panel for vernakalant, which the agency had declined to approve in 2008 due to safety concerns. That time, however, its advisors had given the agency a decidedly positive recommendation. Since then, registry data collected for the drug's resubmission seemed only to raise further safety issues, especially evidence that a single infusion may cause severe hypotension and suppress left ventricular function. Some members of the Cardiovascular and Renal Drugs Advisory Committee, including a number who voted against approval, expressed hopes for further research aimed at identifying specific AFib patient groups who might safely benefit from vernakalant. The drug has long been available for AFib cardioversion in Europe, where there are a number of other pharmacologic options, and was recently approved in Canada. Dr. Paul M. Ridker recognized that there is a significant clinical need for such a drug. However, the results of the safety study that the manufacturer presented to the panel were pretty marginal. Given the negative safety signals and the available cardioversion alternatives, he questioned whether vernakalant represented a substantial advance versus just another option. We'll be right back after this message. The benefits of bariatric surgery may include reduced cerebrovascular risk. Obese patients who underwent bariatric surgery had a 2/3 lower rate of major cerebrovascular events than a matched group of obese residents who did not. That's according to a retrospective study of 8,400 British patients. Researchers at Imperial College London presented the findings at the American Heart Association Scientific Sessions. During 11 years of average follow-up, the incidence of acute ischemic stroke, acute intracranial hemorrhage, subarachnoid hemorrhage, or transient ischemic attack was 0.4% in those who had surgery. It was 1.3% in those without bariatric surgery. That's a significant relative risk reduction of 65%. The cut in cerebrovascular events was mostly driven by a reduced rate of transient ischemic attacks, which is a potentially unreliable diagnosis. But the study researchers say the results also showed consistent reductions in the rates of acute ischemic strokes and of acute non-traumatic intracranial hemorrhages. New findings from the landmark Systolic Blood Pressure Intervention Trial, or SPRINT, show that intensive blood pressure control over 4 years reduced the overall risk of all-cause dementia by 17% compared with standard care. But it was also associated with significant decreases in cognitive function and total brain volume. That's according to results of 2 analyses of SPRINT-MIND, a sub-study of the main trial presented at the Clinical Trials on Alzheimer's Disease Conference. SPRINT-MIND examined the risks of incident probable dementia, mild cognitive impairment, and a composite outcome of both in more than 9,000 patients. Results presented last year showed that intensive control reduced the risk of MCI by 19% and the combined outcome by 15% compared with standard care. Now, 2 separate analyses suggest that intensive treatment of elevated blood pressure can also bring risks. Researchers from Wake Forest University presented more detailed cognitive outcomes in SPRINT-MIND among 2,900 subjects who had a full battery of cognitive testing at every assessment over 5 years. Although there was no significant difference between the groups in the rates of memory decline, there was a greater rate of decline in processing speed in the intensively treated group. Separately, University of Pennsylvania researchers presented MRI findings. Not surprisingly, the standard care group showed a significantly greater increase in white matter lesion volume at the follow-up scan than did the intensive treatment group. But the intensively treated group had significantly more brain atrophy than the standard treatment group. The presenter noted that it was a very small difference amounting to less than 1% of the total brain volume, but it was still statistically significant. You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Steve Simoneau, Steve Stiles, Michelle Sullivan, and Mitchell Zoller. And CardioCast, Cardiology News, and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. And be sure to take our short listener survey. For MDedge, I'm Dr. Jim Dwyer.